topic to discuss pain management in rheumatological patients. So my talk is centered about the symptom of pain, which is an unpleasant emotional or physical sensation, and then evaluation of pain and management. So let's see how we guys go about it. The first thing that the person or the evaluating physician should do is identify the site of pain correctly, whether it's in the soft tissues around the joint or within the joint, cartilage or the bone itself or lot of things. Then after identifying where is the pain originating from, the next thing is to make a good diagnosis on the basis of a good history, good clinical examination, and by and large that should be sufficient, and then support your diagnosis with further investigations if you think they are needed. So, most commonly we make diagnosis of autoimmune joint disorders like rheumatoid arthritis, and after a while I'll show you a few cases and walk you through the problems we commonly encounter. Soft tissue rheumatism like plantar fasciitis, tennis elbow and so on, osteoarthritis which is a cartilage disease, or referred pain from spine like sciatica. The treatment plan has to have very clear objectives. First of all is to educate the patient. It may be a self-limiting episode, whereas then we'll just relieve their anxiety, or it may have a chronic outcomes. Again, then education is important. The objectives should be very clear, and the patient and the treating doctor must be at the same level. So we have to understand what the patient expects from us, and the patient must also understand how much we can deliver and how much we can help him or her. And then third thing, which is very important, is give them timeline. What do you think is it is going to take a month or 3 months or for the rest of their life? And also, the most important in our patients' education is to tell them which drugs they should stop after a while and which are important. As in chronic diseases like rheumatoid arthritis or SLE, patients often get confused and they keep on taking the wrong medicine. They come back after 3 years, doctor, so the answer was that आप गलत दवाई खा रहे हैं, आपके वो बीमारी की दवाई कोई और थी और दर्द की दवा कोई और थी. They get mixed up. That's simple. So first thing is just this is a theoretical thing. Categorizing pain, is it a nociceptive pain resulting from injury or inflammation, or is it a neuropathic pain? Commonly we see nerve entrapments, C6, radiculopathy, sciatica in the leg, and so on, or mixed type. So that's important because it will guide you what medication to choose to treat the pain or the symptom. That's as far as treating the symptom is concerned. So making a good diagnosis and understanding what is the nature of the pain. So the first case is a 35-year-old woman. She's a clear-cut diagnosed case of rheumatoid arthritis of 3 years duration. She was given methotrexate, which is the standard treatment, and she was doing. But in the last 2 months, she has severe pain in joints of wrist, metacarpophalangeal and PIP of both hands. So her hands are becoming active again, and she can't function, can't grip, can't hold objects. So what are the treatment options? She is already on one drug. Just a brief, what is rheumatoid arthritis? It's an inflammatory joint disease. It typically affects small joints of hands and feet, but it can affect medium and large joints. And the onset of disease is preceded by a long prodrome, sometimes over 1 or 2 years, when patients do not have overt arthritis. They just have arthralgias, fatigue, malaise, lethargy. That's important to understand. In the pathology, there is synovitis. So there's inflamed synovium with increased vascularity, in advanced cases, spannus formation. And you don't want your patient to develop this kind of deformities. Nowadays, in modern medicine, we should be able to prevent our patients getting to this stage, not ending up on a wheelchair and not having deformities like this where their function is compromised. So the goals of therapy is, first of all, yes, they want relief of symptoms of all of them, which is fatigue, pain, and so on. And we need to preserve their joint function. They keep on functioning. Now the data is that if after 1 year of treatment of their disease, the patient has good functional status, that is they're up and about walking, and that means that patient will be on her or his 2 feet for even after 10 years. But somebody who has ended up in a wheelchair in 6 months or a year's time and is not improving, that patient has a poor prognosis. So you have to preserve the quality of life, achieve clinical remission, and those with very severe crippling disease have early death. It the 5-year survival is as compared to somebody with advanced heart failure. So management of pain is simple, straightforward, and don't need to educate this audience. NSAIDs, steroids, short courses generally, and opioids. But the pain will not go away unless you treat the disease. And here she is on one drug. Now here the physician has to consider adding more disease-modifying anti-rheumatic drugs or go to the modern medicines which are called biologic drugs. These are targeted therapies targeted against cytokines which cause inflammation in the joint. So NSAIDs are primarily the mainstay, widely prescribed drugs, one of the most widely prescribed drugs in the world and in our country, and they have mild anti-inflammatory effect. They have no effect on the disease course. They will not prevent erosions, they will not prevent deformity, they will not prevent dystocia. They only provide symptom relief through inhibition of prostaglandins, mediated thromboxane, A2, and cofsensing at the site of inflammation. So what are the combinations? This is a popular term. So if one drug is just like hypertension or diabetes. If one drug is not sufficient, you add 2 or 3 and keep on treating until you get your result. So what are the common combinations that we use in our country? Methotrexate, sulfasalazine, hydroxychloroquine. The first line is almost about 25 years old, 1994. This was first reported and still remains a very popular combination therapy. And I'll tell you why is this component important to know in our country. But you can combine any of the two drugs. The more you drugs combine, the more side effects you're likely to have. And nowadays, in the last 15 years, the practice of treating this disease has switched from one drug, which is primarily methotrexate, and then newer agents, which are called biologic agents. Primarily methotrexate, but if it does not tolerate it, we go to leflunomide. Now, this in the middle is a long list of drugs. These are TNF-alpha inhibitors, modulators, rituximab, and so on. And this list is incomplete. We have similar, nearly same amount, more than a dozen, almost 18-20 drugs in the pipeline in the market to treat this condition. They are all targeted therapy. They select one receptor or one cytokine, and which is thought to be pivotal in causing inflammation. So if you knock it out, it's just like having if गाड़ी के 4 टायर हैं, एक टायर पंचर करने गाड़ी हो जाएगी. तो बस यही concept है. Now, why it is important to treat this disease early or recognize early? Because you have a small therapeutic window, which is we say is the first 6 months or max 1 year. If you treat it in the first 6 months, diagnose and treat properly, the patient has a favorable outcome. But if that period is missed for any reason, then the prognosis gets worse as the time goes on. It doesn't mean they can't be treated, but they you wish that they had come to you in the start of their disease. So, and this is long-term data from several prospective studies. Now I'll give you very briefly about these newer drugs which have come to Pakistan. TNF-alpha blocker, etanercept. Infliximab has come very recently. Rituximab has been around for almost 10-12 years. And tocilizumab. Now, all of these drugs are expensive. The first drug to come was rituximab, and currently even now it costs 3,40,000 to give one course. And one is not usually sufficient. Ideally it is repeated every 6 months, but we tell our patients, if you manage somehow, then you will need to arrange for more finances after a year and a half, and so on. Usually 2-3 courses give them long sustained remission. The second drug which came was etanercept, TNF-alpha blocker, which is the first drug to be introduced in the entire world, but came to Pakistan late. It still is expensive. Its per month cost is 90,000 rupees. So generally, we are not able to put our patients unless they have some insurance, somebody else paying for them. It is useful in treating children with juvenile idiopathic arthritis. They usually go into remission after a few months, or somebody with ankylosing spondylitis, which I'll discuss later on. They will get into remission fairly quickly. But in rheumatoid, generally, if you stop after 6 months, they go back to zero, and you have wasted patients' money. So you think of other one. Tocilizumab came to Pakistan about 2-3 years ago. Now it was initially an IV injection, where again it was costing 1 lakh rupees a month. But now there is a subcutaneous preparation which is about 35,000 rupees per month. So it's a substantial cost reduction. And we hope with these price wars and competition between pharmaceutical companies and biosimilars, the cost of treating this difficult disease will reduce even further as happened in other specialties. So we're looking ahead to that. My second case, so this is about rheumatoid. If you have questions, I'll answer in the end. Is another important disease. It is back pain in young people below the age of 40 or 45. So he's a typical patient, 23-year-old university student in the prime of his life. He has a complaint of low back pain of a year's duration. It is worse in the morning and improves as the day goes by. He responds to a few days course of NSAIDs, but it keeps coming back. He self-medicates, he went to a doctor, then he's been taking them on his own. There is no past history of skin disease, gastrointestinal disorder, or family history of psoriasis or inflammatory joint disease. On examination, there is limited flexion and extension of the lumbar spine, which we call the shoulder disc. The right sacroiliac joint is tender. The inflammatory markers are raised. PSR is high, CRP is high. So this is inflammatory back pain. And generally these patients will not show anything on their X-ray. I'll show you the earliest thing that we can do is order an MRI of pelvis for sacroiliac joints. And you need a good radiologist who understands what he's asking for. Otherwise, you get a wrong report, or they don't understand why you ordered this scan. So the referring doctor and the radiologist must be on the same wavelength, and this is what we are looking for. And here in the scan, you can see bright images here. You can see bright images on the sacral side as well as on the iliac side, parietal sacroiliac, which in an X-ray will not show up. The X-ray shows up much later, 2 years, 4 years later. By that time, perhaps it's too late for the patient. So this is another patient with most normal sacroiliac joint on this side, and here you have the stir sequence, which shows inflammation in the sacral side on the left side. So unilateral sacroiliac. So interpretation has its own pitfalls, but nevertheless, in an appropriate clinical scenario, it's a fairly good thing to go ahead. Now, sacroiliitis can be picked up. Not everybody has luxury of getting MRI done and such kind of facilities. So you can also ask for somebody with chronic 5 years or 6 years history of back pain in a young person. You can simply ask for an X-ray pelvis APV, just pelvis APV, and it will show up the sacroiliac joints. You can see grade 1 suspicious changes. There's slight sclerosis here at the inferior margin, more on the iliac side or bilaterally, and as these are slightly more enlarged, then you get narrowing of the space and then erosion starts coming up. And finally, this is very classical bamboo spine, but it's too late for the patient. Although we have got way made the diagnosis, it looks very fine in the museum of X-rays, but it's more help to the patient. Nobody should end up like that, and it is possible nowadays. So what is the treatment of this condition? The term we use is spondyloarthropathy. It's a huge term. It encompasses all forms of inflammatory spinal disorders. Again, education. Patient will live it for 40 years or 50 years of his life. Exercises early on. You don't want patient to become flexed forward. Otherwise, if their neck gets flexed, they are looking at the floor all the time. They can't look up. They can't. If they get flexion deformity, they can't lie straight. They have to lie on the side. They need help somebody to get them out of bed. So exercise and education is very important. NSAIDs, yes, they are useful. Before these drugs with biologics came along, NSAIDs were the only treatment for this condition. And they were put on those when you had somebody with ankylosing spondylosis, they took NSAIDs for the rest of their life. There is evidence that somebody drugs like celecoxib, data is on celecoxib, that if they're given, they prevent that bamboo spine from occurring, nuisance discomforts from occurring. But the treatment which is revolutionized are these biologic drugs. You get excellent results. It's very, very satisfying treating such a patient, etanercept, infliximab, and we have a new agent, secukinumab. The first two agents again very expensive, 1 lakh rupees महीने का खर्च. So secukinumab is less 40,000. So our decision is not on what European guidelines or American guidelines are. Our decision is on what patient can afford. So unfortunately, although these are all equally comparable drugs, but we will prescribe what the patient can manage. And sulfasalazine is an old drug. It's been around for more than 50 years. It works with somebody with peripheral arthritis. So if they have ankle problem, finger problems, and so on. I'll just move on to. I'm short of time. So you have a 27-year-old who has presented with back pain for 10 days duration. It started after lifting a heavy weight, and it is mostly around the left lumbar area and at times radiates to the glute area. It worsens on changing posture and bending. Again, the education, management techniques, the most important message is that late nahi jana pada. Uthe, chale, active rahe. The more they lie down, bed rest is for a few days, or as long as once they are able to move about, they should get up, and otherwise they end up with a lot of muscle atrophy, disability in long term. Now you have, Dr. Asad is also here, so we're colleagues and friends. These are the sort of patients we share between them. My final case, a 58-year-old Imam Masjid has suffered from bilateral injury in the last 4 years. Now he has 6 weeks history of low back pain and left-sided sciatica. His hypertension is not controlled with losartan 50 milligrams. He has passed kidney stones many times in the past 20 years, so really complicated story. On examination, straight leg raising is 90 degrees on both sides. He has hypoesthesia in L5 dermatome, and MRI shows L4-5 central distribution and central stenosis. So what is the management of this situation? Here is the MRI, you can see in the L4-5 level. There is this blood and spinal stenosis. Complete cut off. But he's up and about, and that's the thing about MRIs. Sometimes MRIs are drastically horrible, but the patient is not too bad, and vice versa. So, in this situation, activity modification, education, NSAIDs in acute settings, sometimes if there is inflammation, they work. Sometimes no NSAID works, no need to continue if they don't work. Tramadol is an opioid, it helps. Muscle relaxants, spasm. And for this kind of neuropathic pain, gabapentin, pregabalin, and duloxetine are used to. You have one drug you're comfortable using, you know how to start. It's a dose titration process. All three. Steroid tablets are used by some clinicians. Sometimes they're effective, but those are exceptional situations, not a routine practice. Exercises, manipulation help, and epidural injections will work for the neck pain. So if somebody who has very bad sciatica and is not improving, you can ask your colleague who knows this technique, or pain specialist we have now, or our spinal surgeons, so they will do this for us. Sometimes most will improve, most cases of sciatica will improve over time, where some who do not. Now what do? You would ask General Asad to please have a look, and he had it for 2 months, no improvement. So what is the sort of patient? There's somebody whose straight leg raising is not improved. He's still 30 degrees पे उसकी चीखें निकल रही हैं. The congruence of findings on neuromuscular examination, imaging, and in the Western countries, absence of litigation, workers' compensation. Because वो कहते हैं जी मैं ठीक ही नहीं हूँ, ऑपरेशन हो गया, मुझे और रिलीफ को अलाउंस दे. वो ऐसे पेशेंट्स वो लोग नहीं करते उसको. So you have to have clinically. That sometimes our patients are diabetic. Their pain may be diabetic radiculopathy. So you need to differentiate between these things. And then absence of negative prognostic factors. Females, depression, older patients, low level of education, very severe back pain. But generally, if you a straight leg raising is a good clinical sign, and the success rate over 95%. Now, finally, the last minute, a 53-year-old female has a 18-year history of low back pain. It started after her third child. It's a routine rheumatology practice in Anchor in the family medicine as well. There have been several acute episodes of back pain, sometimes associated with radiation to legs. She's now recently had converts. She's unable to stand or walk for more than 10 minutes. She's tired, has difficulty sleeping. On examination, there is mild tenderness over L4, 5 vertebrae and flexor joints. Flexion is painful, straight leg raising is normal, and there is no neurologic deficit. She's obese, and so what do we do for her? And this is her MRI. L4, 5, L5, S1 both show this protrusions and stenosis. Here it is a multidisciplinary board. We need help of physiotherapists. We may need to refer her to a psychiatrist. And the patient has to be educated. It is a cure, not cure strategy. So ये कोई कहना चाहिए कि बहुत से इसके आपके symptoms दवाओं से नहीं ठीक होंगे. हमें कुछ और इसके लिए करना होगा. And I'll tell you what. And the emphasis is on vigorous functional restoration. Acupuncture has been tried. There is more trials, modest to sleep, and exercises improve functional status. Sometimes drugs we will use again, low-dose narcotics, central acting agents like pregabalin, behavior therapy, and flexor joint injections and epidural steroid injections. Just a few slides on exercise. So this is the kind of pamphlet I give to patients, we give to patients in our, ये आपने एक्सरसाइज करनी है. अगर आप चाहते हैं कि बार बार डॉक्टर के पास ना आना पड़े, तो ये एक्सरसाइज का एक प्रोग्राम है. एंड these exercises are individualized. You can tell them now they have access to internet, YouTube, वो खुद निकाल के ले आते हैं. But certainly it's important that you have to do these kind of exercises on a regular basis, twice a day. This is hard. These are very easy to do. They just bring the heel onto the hip and then slide forward. अगर रात को लेटते हुए कमर में दर्द होता है, बहुत अच्छी एक्सरसाइज है. 10-10 दफा दोनों टांगों से कीजिए. Abdominal contraction, again useful exercise for chronic backache. सांस अंदर लेके उसको होल्ड कीजिए और फिर उसको रिलैक्स कर दीजिए. Straight leg raise, again अगर for any during the day if they get any back pain, आप काम अपना छोड़ दें, जाके लेटिए, 10-10 दफा ये लेग एक्सरसाइज कीजिए, उसके बाद आके आप दोबारा अपना काम शुरू कर दिए. वरना रूटीन से सुबह शाम काम करते रहिए. Again a very useful exercise for knee to chest stretch. Do it twice a day when you get up in the morning, then again do in the evening. Keep it on a regular basis, and then of course walk 10 मिनट 15 मिनट जितना आपसे होता है वो कीजिए. Back strengthening exercises की हर एक को नहीं recommend कर सकते, but certainly in younger age group these are useful. Piriformis stretch again, lower back, gluteal area pain, वहाँ पे stretch हो रहा है. This is again is a useful exercise to teach them. And I think I'll stop here. Thank you.